Happy Thursday Night Live. Hello, everybody. Look who I have with me today. A very, very special dentist from Dubai. We met a few times already.
Yes,
We were just together in Vienna.
Vienna.
Yes, it was such a good meeting in Vienna.
It
Um,
was.
and I got to see your book. You brought me one, so thank you so much. You have it right there behind you. So excited for you to share with our listeners about your book. I'm going to go ahead and introduce to you guys our speaker. If you're an Airway Circle member, you're watching this live, you get to interact with us and ask questions. But you can also watch this as a recorded version. If you guys are not part of our membership yet, we have over 200 webinars recorded just for you that you can go through with different topics. It is a multidisciplinary study club. So you can watch on your own convenience since everything is right there in one place. So let's start. Dr. Tayara is an international award-winning pediatric dentist, an oral health speaker, a book author, and a mom of three. How do you do it with three? She is the founder of SmileHealth, a children's health education company. She offers functional and integrative oral health care and early corrective orthodontics with a focus on whole body health and well-being of babies and children. She currently has her main practice in Dubai. What else can I add to that? Welcome to the Airway Circle stage. Thank you for being here.
Thank you so much for having me. It's a pleasure to be here. And I can't wait to share a few slides with you and, have this conversation.
Thank you. So first,
We've
how did
been,
you fall into this world? The title today is Beyond Baby Teeth Airway Health. How did you get
yeah,
into airway?
I actually shared on the first few slides
Oh, perfect.
because when you start as a pediatric dentist, you learn so much, in dental school and then in your residency, but then when you start seeing patients in real life, in a private practice or in a hospital setting, things change. You start to, learn how to unlearn,
Yes.
and you also, realize that there's so much more than just teeth, right? And this is the story that I wanted to share actually in the beginning of my presentation, is how I got into the world of airway, through pediatric dentistry, because it's a fascinating world.
100%. We're so
Yes,
thankful to have you. And we need more and more pediatric dentists join us. There's so much out there. I mean, and we know that you guys are so crazy busy dealing with everything else that you have to deal with as a
yes,
pediatric dentist. So we're so grateful for those who choose to go into airway and look a little bit beyond the baby teeth and try to guide these parents for or these children, through their craniofacial growth and development and airway health journey. So thank you so
true.
much for what you do, and you're welcome to share your screen.
Okay, let me see how I do this.
Okay, for
How
anyone
do
who
we
is
do
here live,
this?
you guys are welcome to ask
Hmm.
any questions, say hi, let us know where you're from and your specialty. And also, as we get
Hmm.
to the end of the year, guys, Myo Circle is our advanced myofunctional therapy course. It starts January 1st. So make sure to join that. We only have 6 spots left. We only teach this once a year. So make sure to join that. And another thing I would like to share with you guys. Oh no, there's 2 extra things. I'll share at the end also. But um, we have a gift, a membership. I had a dentist reach out to me not long ago and said, Renata, I want to gift a membership to my hygienist. How do I do that? So now we have a way for you to do it. It's a great holiday gift of learning. Everybody wants to be in and get to see our research folder and all the other resources that we offer on Airway Circle. And then the third thing, really quickly before we start, Airway Circle Retreat. You guys have been asking us. So save the date, April 10th through the 12th. It's going to be in Hilton Head Island, South Carolina, right where I live. And it's absolutely beautiful. We're so excited to share with you guys who our speakers are going to be and everything that you're going to learn that weekend. It's going to be very limited. You have to apply. We're going to pick a multidisciplinary group. So it's very diverse. Anyways, we can start. Here we go.
Nice. I wish that retreat was a bit closer.
We will have one in over there on that side
Yeah.
eventually. We may do
Mhm.
one in Dubai.
Need to have one in Bali.
Yes.
Are you able to see my screen?
We can. Can you click on
Yes. Play.
yes.
Okay, perfect. So, beyond teeth, airway health. So, I'm always saying in every lecture I'm giving, in every talk I'm doing, in every conversation I'm having with other dentists or, medical professionals that we need a shift of practice. So, a little bit of me. This is me in the center of my family. I have my twins. My twins are almost 13 now, so I'm dealing with teenagers and a toddler at the same time. This is baby Lara. She was a few months here, but now she's 16 months. And we are a very international family. I grew up um, in Montreal, in Canada. I'm originally Lebanese, Venezuelan, and my husband is Dutch, so a little bit all over the place, and I'm practicing in Dubai. So, what I wanted to share today is how I got into the airway health through pediatric dentistry. When I started my career, I was freshly graduated from pediatric dentistry, and I was, treating teeth, treating cavities, doing crowns, doing space maintainers, etc., etc. And then I started having stories like Alexa stories where I have recurrent cavities, parents are brushing, she's eating well. We have relapse of cavities. Parents keep asking me, what are we doing wrong? We're doing everything right. And then suddenly, the airway health um, became something that I need to look at because mouth breathing became a topic or a risk factor that I had to look into it. Now, um, this is a diagram that I made myself, and it's also on my website, but I we realized through the years that the diagram of how cavities are caused, change through our learning. And what I became to realize that when someone asks me, why does my child have cavities? It's not only the diet, eating sweets, brushing your teeth, but it's also about, screening their vitamins. It's also about having the right questions about what they're eating. It's also about checking whether they're mouth breathing or not, whether they have airway issues, whether they have allergies. It's also about checking their genetic components, the caries risk of parents, also about the dysbiosis or how the microbiome is, the disturbance, the oral flora, etc. So it's interesting when you gather those things and when you learn how to look to your patient as a whole, you realize there's so much more than just teeth. Um, and you realize that dental and sleep issues are very deeply connected, especially in our pediatric population. Now, what I came to realize too is that every mouth tells a story, and it comes down more often every day in my practice to a child who doesn't sleep well. And we have like digital 3D scanners now. The dental world, especially the pediatric dental world, is so we're so advanced from a technology point of view. We have 3D scans. We have a lot of artificial intelligence built in our data that can, tell us about problems much faster and in a more efficient way. And you can see right away when you scan kids' mouth, for example, here, you can see how you have a high arch palate, dumped in teeth, cross bites, everything that tells you that there's something wrong beyond just the teeth. And this is usually how you realize that, you start asking the parent questions. Is the child snoring? Does he have allergies? Is he focusing in class? Is he, fatigued? Is he hyperactive? You see crooked teeth, you see no spaces between baby teeth. I can check the tonsils on my exam. I can check, okay, they're huge. And you start seeing that what we see is way different than what's under the surface. So this is a bit my journey, from a pediatric dentist to now, a pediatric dentist with a scope on early orthodontics. I expand, small jaws as early as 3 and 4, and I focus a lot on airway and, seeing the child as a whole. And this is what I was telling Renata earlier, that I learned to unlearn. I learned to connect the dots. And this is a little bit of the reports that I get back from my pediatric ENTs. I have 2 pediatric ENTs that I work with on a daily basis. I detect airway issues, as soon as I see young children, sometimes from the age of 1 or 2, and then I get the reports about the adenoids, the tonsils, the airway, and I'll show you a few of them. So again, I get lots of parents coming, when I ask them about how their kids are sleeping, they're telling me, oh, my child opens their mouth during sleep, it's so cute. When I ask about snoring or sounds, there are a lot of things that really just pass by them. They don't even realize that it's a red flag or it's not normal. A lot of parents still think it's normal that, if their child is snoring or making sounds or, doing those extended neck extensions. We know today that we breathe 17,000 to 30,000 times a day. In the first year of life, the brain size doubles. And this is the foundation of learning and memory. At the end of 3 years, 80% of the brain achieves its adult volume. But we know also that the quality of sleep is as important as the quantity. And still, there's a lot of awareness to be raised when it comes to giving knowledge or, teaching, educating parents in, how a child should be sleeping and what is a good quality of sleep. So you can see here the child sleeping. We have a low tongue posture. Renata can definitely comment a lot on that. Tented upper lip, the gum sometimes visible. We have an open mouth. A lot of parents, for example, come and complain to me, oh, my child has really bad breath when they wake up. This is already a sign, a red flag, investigate, ask. So when it comes to a child sleeping, we want them to be closing their lips. This is like the ultimate ideal position when you have, this is my baby when she had a few months, you see how her arms are like just laid back. She's relaxed. Her lips are closed. No sound, is an indication. Any sound is an indication of resistance of airflow. And don't ignore the snore. Snoring is, again, not normal. If your child is snoring, this is a red flag. We need to see the ENT, check with your pediatric dentist. There's a lot that can be done, and the earlier, the better. Snoring is the most common symptom of a condition called obstructive sleep apnea, and it affects 5% of children. It's as common as asthma, and 80% of people are globally undiagnosed. And it's still something that parents think it's okay, but if someone were choking your child during sleep, I'm sure you would be livid. Children with OSA, they have brief episodes of suffocation on their own all night long, night after night. So open mouth breathing, audible breathing, tossing and turning, unusual sleep positions. When you ask, sometimes I ask the parents of my patients to take videos of like a minute while their kids are sleeping. I can see the neck hyperextension, I can see tummy sleepers, the bum in the air, sweating, grinding, bedwetting. All those are signs. And when I and take my sets, and also I get them back sometimes from the ENTs, you can see um, the narrowing of the airway already here on the ceph. And this is, this is what shows you that this child is struggling to sleep, and that could, explain also the poor concentration and attention during the day, being tired, his brain is not oxygenated well at night. Sometimes they have this blurry memory. All those can be related to, sleep issues and breathing. And again, many parents, they come to me and tell me, oh, sometimes I send actually to ENTs, and then, the child comes back with his parent, and the parent tells me, oh, the doctor said they're just gonna grow out of their issues, but it's not true. They do not grow out of these issues, they grow into them. So super important to highlight that to the parents, that it's not true that, they just grow out of them. They actually get worse. And the earlier we treat, the earlier we can help them, having a better sleep, a better quality of life, and reaching their potential in life. The surgical removal of enlarged adenoids is, pretty much very, very common procedure now these days, but I still in my practice see a lot of relapse, and this is, a nice discussion that would be great to have it with Renata, because, what do we do for all those kids that undergo the surgery of removal for adenoids and tonsils, but then they come back to me a year later or 6 months later and they are still mouth breathing? There's a lot to do, beyond doing the surgery. I see it every day in my practice. I see almost 70 to 80% of children, they still have a significant degree of breathing dysfunction after surgery. And that's how we send them to a myofunctional therapist. Sometimes we use the tapes to train them again, of course, after ensuring that they are able to breathe from their nose. It's a great book that I wanted to share with you, Treat the Cause, Treat the Airway, and shows you how symptoms, are the way Mother Nature gives us to compensate and adapt. So I want to talk a little bit about the influences on airway development for a child. The orofacial airway screening, you've probably seen this before, but I'll just review it a little bit. One of them is mouth breathing. I just want to try to go to my cases a little bit just to show you what I see a little bit every day. This is Lucas. He came to me. Mom went to other dentists, and they just told her, oh, don't worry, come back. We'll do something when he's 11 or 12. And I saw this kid, he has this open bite, asymmetrical, teeth dumped in, narrow palate, high arch. There's a dysfunctional growth that is completely obvious, a lower tongue posture, dark circles. He's tired during the day. Mom is like really, worried, but, she's not really getting the right support system or help. And then of course, he's being treated now through the team. So he's being seen by an oral myofunctional therapist. She's doing a lot of training for him. We saw that he has a tongue tie. We're expanding, it's gonna be followed up by a treatment of clear aligners. So he's being taken care of, but he's been through a few years where there was no treatment, there was no support. The mental strain, the lip incompetence is a sign when you do your orofacial airway screening. Does the patient struggle to keep his lips together while at rest? So those are one of the first signs when you see a child on your chair, and then you realize, okay, then I need to do something. It's very hard for him to close his lips. So, let's see what's the root cause. The hypertrophy of tonsils, in grades, of course, it doesn't have to be, when you're a pediatric dentist or dentist, you cannot do perfect measurements on kids while you do sometimes your exam, but at least, to understand and estimate, what are huge tonsils to what are, within the normal tonsils. Of course, kids, especially in Dubai, we have a polluted city. We have a lot of air conditioning going on, and sometimes kids, they get sick a lot. They have a lot of allergies. So it's good to also take that in consideration. Um, the tongue score of Malamti, sticking their tongue, checking everything. There's so many ways, to assess for visualize the structures, but um, when you see an obstruction like this, like a class 3 or class 4, is also something to take in consideration. The tongue tie, I'm sure Renata has a series of videos and webinars to talk about that, but it's something really to look to. I still see a lot of dentists not, considering even looking at the tongue movement and the tongue freedom. What we do in pediatric dentistry is we also go through the breastfeeding history for a mom. So we always ask that question to the mom, was your child, was he breastfed? How long did you breastfeed? Did you have any problems breastfeeding? And then sometimes, things come up in the interrogation, and then you see, oh, he wasn't latching properly. Oh, I felt he wasn't getting enough milk. Oh, it was horrible. It was a nightmare. Things like this, they ring a bell. So this is the Vienna Airway Congress where I met Renata too. And, she was a great speaker, great insights. It was a lovely team, and I can't wait to be back next year. The scalloping is mostly for adults, not for kids, but scalloping is a sign that we need to see. The tongue palatal suction, assess for tongue space. Um, how is he, swallowing? All those things are super important to see. One thing also that is a huge red flag in pediatric dentistry is, when you have a complete bone two or like zero spaces between baby teeth. And, this is where you should really start, questioning what's the cause. Sometimes I even see crowding, in a baby teeth. So, there's not even enough space for the tongue to go up. Dental wear, we don't really see it a lot in kids, but sometimes when things are mostly severe, we see it. The dark circles, this is a very important sign in pediatric dentistry. We see a lot of pediatric patients with dark circles, and this is really there, a red flag for you to start asking a question about the sleep quality. I was surprised in April 2024 to see on New York Post an article about dark circles under your child's eye, and there was a good content there about airway and sleep. So I was pleasantly surprised. The profiles, the retruded maxilla and mandible, this is a shot that I took while I was picking up my twins a few years back. And as a pediatric dentist, you run into a school for pickup, and then you just start looking at those places, and you're like, oh, this is a tongue thrust. This is a retruded mandible. So it's just funny how when we are a dentist, we check, facial profiles. Pathway to restore airway health. So the complications of not treating tongue tie in children. This is also what you see in the daily practice when you ask a lot of questions. Breastfeeding, feeding challenge, did you have them? Speech delays. A lot of kids, they come and then, the mom is concerned about, a certain pronunciation of letters. And then, when we examine, when we check, we see a tongue tie, we see a narrow palate. So once we start treating all those factors and putting all the pieces of puzzle together, sometimes the pronunciation is so much improved. Grinding. So still until today, I have patients coming to me complaining that their child was grinding their teeth, and still they were dismissed by other dentists or by doctors, and they told them, oh, it's just stress, or just, you know, they'll just grow out of it. But when you see a child regularly and you hear that from a mom, there is a room to investigate. Usually, grinding at night is associated with an impaired nasal breathing, a restricted tongue mobility, and tonsil hypertrophy. And most, maybe 90% of patients who grind at night that I see daily, they have an airway problem when we do the airway assessment with an ENT. Restricted tongue mobility was found to be an independent risk factor for grinding in children. And there's a synergy between the hypertrophy, the restricted tongue mobility, and the nasal obstruction. The prolonged pacifier use is also something that we look at, right, when we see kids, because I see kids starting, a few months. The first dental visit, as you know, is at age 1. So the AEPD had a huge motto a few years back, get it done by age 1. And this is really to detect problems like prolonged pacifier use, tongue ties, tongue mobility, abnormalities. It's mostly a counseling when we talk to moms, and then we see how they're doing things, and then, we put them on the right track. And this is what we call the dental home for a child. And we know now that a prolonged use of pacifier encourages the tongue to go on a low posture and goes against a nasal breathing. So the earlier you can wean your baby or your toddler from pacifier, the better. We've spoken about ENT follow-ups and referrals. I'm gonna move on, but this is a interesting photo to see how you can even detect on a ceph how big your adenoids are, and the pathway of your airway, how narrow or wide or normal it is. What I do on a daily basis is treating small jaws. And expansion, these days, I will talk about it a little bit later. But basically, the goal of early interceptive orthodontics is to, we call it the 3 R's. So reestablish function, redirect growth, and restore occlusal balance. And we still see from older generations extraction cases for ortho. And we know today that, we want to, as much as possible, avoid that, because when we extract premolars, when we extract teeth, especially posterior or laterals, we are removing a tongue space, and we are, being a factor for those adults having poor sleep. So the earlier at my practice I can expand for a child, the earlier I'm doing it. And this is really a revolution in the treatment of sleeping, breathing disorders, the rapid maxillary expansion. And this is really our, daily thing. It's the bread and butter in my practice. We expand early. We expand as soon as, we see those little red flags coming out. Now we have so many tools. We have, the conventional hyrax. We have customized palatal expansors. We have the removable plate. We also have now the new thing, which I've been using now for a few months, the Invisalign palatal expander, which is so easy and super cool. We are increasing the upper airway volume. We are reducing the nasal resistance. We are collaborating and changing the tongue posture. And we are even helping the mandible rotating and, meeting the upper jaw in a better, healthy way, and opening the airway. So re-guiding the growth, I try to do it as early as possible. I see anterior cross bites as early as 2 or 3 or 4, and I treat them right away. While other dentists sometimes, turn their back and, tell the mom, okay, come back next year or whatever. Cross bites are super important to treat early as soon as you see them. Now we have the clear aligners, that are great way of an easy way of doing it, very motivating for children. Um, but it also should be combined with re-education to restore nasal breathing, tongue tone, and other muscle patterns. And you can see in those clear aligners treatments for kids, things move really fast. And sometimes in 4 or 5 months, we have an excellent result. And sometimes when we even finish those phase ones, we don't even have to, we don't even need a phase two, because the symmetry is established, the crossbite is corrected, um, the functions are corrected, the tongue, is trained to be more on the top. And then you can see like this is like a 20 aligner or 25 aligner treatment, and then we're pretty much, in the right track towards a happy smile and a happy sleep. Again, crossbites, very simple. You expand, you refer to an ENT, you assess the airway, and then the job is almost done very early in life. This is another child, complete anterior crossbite. You can see it. And, this is only like 5 weeks apart of starting the expansion. Of course, we will need to tract a little bit. We need to do a bit of traction later. And then I usually complete with aligners just to maintain and having every stable. But if you've seen that child, when he came first, the mom was telling me that he was bullied. There's so much about mental health that we ignore for those kids, but it's important to consider it and treat as early, and because it really affects them. And you can see even how his cheekbones are now better after 5 weeks. And then he was smiling, he was happy, he was sitting on the chair, in a very positive attitude that is completely changed. I want to talk about a little bit the mandibular advancement, how when I do it with clear aligners, it also opened the airway. And you can see here when you have a huge overjet like that, the only way you can treat it when you have a growing patient, in the old days we had the twin block, now we have those wings with Invisalign. There are other also softwares like the Angel aligners where they use those occlusal stops. But it's a great way to advance the mandible, open the airway, re-establish the occlusion, re-guide the growth, and giving that girl um, a better smile and a healthier airway. The profile also improved a lot. This is this is also another case. Celia also came to me because her mom was worried that, her classmates were saying mean things, and she really wanted to treat this and uh, try to find a solution for her smile before things get out of control, and then she was not feeling well socially. So that was a simple aligner treatment that was done, I think, in 4 or 5 months, where she had the incisors in a position of a crossbite. We re-established the smile. She was super happy to smile again. She was very, very, very committed to wearing her aligners, and Sometimes I see that a lot in that age range, between 6 and 10 or 6 and 11, where I feel that those kids are much more committed than teenagers. And I also see that parents don't have as much faith in their children as sometimes they deserve. A good find that I found on Amazon a few months ago, and I'm using for my baby, I found those nasal irrigators that are super, super healthy. And just a reminder to, sometimes before you run to an ENT or investigate or the people or worry, sometimes just clearing the nose of your baby or your toddler goes a long way. So the future, and this is something that we also spoke about in the Vienna Airway Congress, that the future of pediatric dentistry in general is the facially airway generated treatment planning. When we not only we look about teeth, but also about treating a child as a whole, his airway, his sleep, his tongue, his his posture. When I was in my residency, one of my research projects was looking into the relationship between class 2 subdivision, so asymmetrical bites, and idiopathic scoliosis. And in my career so far, I think I have diagnosed 5 or 6 scoliosis girls, diagnosis in girls because of their asymmetrical bites. So we know today that everything is connected, and we try every day to, connect those pieces of puzzle. Um, we know that one of the major things that we need to do as a public health intervention is promoting airway health. So I'm all here for that. Um, I hope I, brought a little bit of empowerment to join that movement through the Airway Circle. On Instagram, I am at Dr. Tayara, and then happy to always connect with you and share and answer any questions you have. And thank you again for the Airway Circle and for Renata to have me.
Yay! That was wonderful.
Yeah, thank
Thank
you.
you.
Let me see
Thank
how
you.
I
Thank you.
can get
Thank you.
back to you and stuff. Share. Oh my God, I need to
Yay! Oh my goodness,
getting
that was
more training.
wonderful. Girl,
Mm. Thank you.
those cases. How
Oh,
blessed
I
are they
have,
to have you around?
yeah, I mean, we do so much. I mean, I've done I had a case last month. I think we're gonna publish it soon, but I'm doing clear aligners for a 3-year-old. Can you imagine? And he's doing amazing. He's like literally like complete frostbite. And no one wanted to treat that. You would be
Yeah.
amazed. Like traditional orthodontists, they really don't want to see kids. They're like all about,
Mhm.
come back when you have all your adult teeth. And I
Yes.
hate that. It just is, it boils me, makes me boil.
Oh my goodness,
Yeah.
that is wonderful. Thank you for sharing so much with us. I do have a few
You're
questions.
welcome. Yes, of course.
Um, we have so many parents that call us in the myofunctional therapy practice as soon as they start learning about mouth breathing and how detrimental it is. But sometimes these kids are 18 months or 2 years old and they call, they say, what can I do? My child is mouth breathing. What would be your answer?
I mean, when they're very young like that, simply observing them when they're sleeping, for example, at night or during their nap. And if you see that your baby of a few months or 18 months is opening their mouth at night or during the nap, all you need to do sometimes is just closing, his jaw. And then by just doing this simple gesture, you're just encouraging them to, have their tongue beneath their palate. And of course, we need to make sure that there are no allergies. If we're talking about a healthy toddler. One other thing that I also like to highlight when I speak to parents is, do you have so much carpets, in the bedroom of your child? I had a patient, she had like around 35 teddy bears, in her
Yes.
bed. And those are huge sources of dust mites,
Mm-hmm.
allergens. So there need to be an awareness to be, like a airway awareness in houses and homes and families and community, right? About removing all those soft toys and teddy bears and keeping them in the play area outside or
Mm-hmm.
in the space that is not reserved for sleeping. Your carpets, taking them out, having the elements that attract dust mites and allergens as minimum as possible in the bedroom of your child. This promotes good airway health. Clearing the nose also before, if you see that your child is congested, that there's a change of weather, there's mold, there's moisture in the room, in the house, clear their nose, right? Aerate the rooms, clean your AC, your air conditioning ducts. What I do is I sanitize sometimes also the curtains, the couches, and you would be amazed those
Yeah.
machines how much they remove, literally like this much
Uh-huh.
of black stuff. So all those, routine gestures, just like you shower, just like you do your carpet cleaning, every 6 months in the house, this is something that should be done, in a household. So yeah, those are something sometimes I go through with moms, I feel like I'm having a coffee morning with them.
Uh-huh. Oh, that's great. Yes, yes. Because, as moms, we kind of freak out. Oh my gosh, they're mouth breathing. What do I do? Nobody will see them this early. But there are several things that you can do at home to
True.
improve the air quality, to help that patient breathe better before they need any treatment or they're ready for any treatment. Um,
Very
why
true.
why is it so important to treat the whole child, not just the teeth?
Mm. I mean, I think this is like, a great opening conversation, especially and I see it because moms and dads, they come to me for teeth. And when I start talking about, is he hyperactive at school? Is he focusing well? Then, we stop talking about teeth and they're like, well, then, okay, we need to do the expanders. We need to treat those cavities. And I tell them, I don't really care about the cavities. I care about the root cause.
Mhm.
What's causing the cavities? What's the point of drilling and filling today if they're going to come back to me 6 months later and I'm going to have to drill and fill again? I'd rather not do anything now and just try to investigate with you, why is he having so many cavities? So this is why we treat the whole child. We wanna have them have a better quality of life. We want
Mhm.
them to sleep better, to thrive better, to reach their full potential. How many kids you meet every day where you see that they're smart, they can do so much better, but they're not sleeping well. They're so cranky.
Mhm.
They're moody. They come to your chair and you feel like they cannot sit still for 5 minutes. So I think this is the importance of treating the child as a whole.
Perfect. What is your protocol for sleep studies for little ones?
What is so? Sorry?
Sleep study. Do you do any sleep studies? Do you recommend little ones get
Um,
sleep studies done?
I I actually met a company, Vivos, that actually they're
Is it
because
the
I'm
ring?
I'm also, yeah, yes, exactly, the ring. And now this is something that we're trying to implement in our center, where we give the ring to the parents, and then we have a little bit of data, about their sleep. But I still don't have a lot of feedback about that. But it's definitely something to look at. But for now, what I notice is, because I'm working very tightly with those pediatrics ENTs, we are treating so early before even we need, to do sleep studies. And just
Yes.
by interrogating the parents and,
Mhm.
getting a little bit of a feel how they're sleeping, the volume of the adenoids, of the tonsils, we're really and also by working with speech therapists and myofunctional therapists, and putting that taking the tongue to the gym, basically, we're really reaching a level where we don't really need sleep. I feel sleep studies are very good for adults,
Mm-hmm.
but if you're seeing really early growing patients, it's something that you can even not do. You don't really need to do a lot of sleep
Mm-hmm.
studies unless you have a very complex case
Yes.
where you've done your, adenoid surgery, for example, you've done your myo, you've done the expansion, everything is done, and you're still seeing something wrong, and then you go for a sleep study. But usually, in 99% of my cases, when I clear all those pieces of the puzzles, you know, it's you have
Sleep
you have no
improves.
idea how moms, they come back to me and they tell me, oh my God, my child has transformed. He's like a
Mhm.
happy person, he's concentrating, he's focusing, he's serious about school. I mean, you see a transformation.
Ah, that's
that's
incredible.
that's why the earlier the better,
Yes.
and when you treat an adult with all those problems that have lingered for 30 years, it is so hard.
I know well. Having to go through the
Yeah.
Marty and nasal surgery and all these things I've had to do. Um,
Exactly.
Tell us a little bit about the IPE, the Invisalign Palatal Expander. What,
Yes.
how has your experience been? I have two patients right now
Yeah.
that are getting expansion with the IPE. One of them, 16-year-old boy, has split the suture. You can see it on the scan beautifully. The 13-year-old sister did not.
Oh.
What is your age? How are those cases going?
Well, the minimum for an Invisalign palatal expander is for you to have the first permanent molars. So you
Perfect.
have that, you need to have them like well erupted. So that usually doesn't happen, in most kids before 7.
Mm-hmm.
So 6, 7 is a good age to start that. If I have a child before that age, because I do a lot of expansions on 3, 4, and 5-year old, and for those I use just the typical customized fixed palatal expanders, and I just widen. But the IPE is great for when you have a child who is 6 or 7, first permanent premolar in. And what I found is that first, there's a huge rate of acceptance of the child, because when you show them the video with the cute little white plate, it doesn't even go all the way to the front. It's literally a little bit in the back, and it clicks
Mm-hmm.
on the it clicks a little bit, right, on the palatal, and a little bit on the occlusal side of the teeth. And then it's so easy, right, because they wear it, they change one almost every day or every other day, and then it's thin. It doesn't interfere with much. You can do a full expansion in like 2 months. You're done. And
Wow.
then it's nice because it's a continuity towards their clear aligners. So everything is done. That ugly duckly stage that parents hate in their kids is all corrected. So it's I find it a very innovative, modern, simple way. And the best thing about it is that you can eat and drink, right?
Yes,
With it. So what more do you want? It's
exactly.
it's a really nice tool. But again, in pediatric dentistry, there's not one recipe that goes for all.
Mhm.
You need to see your case and select and see, okay, I had a mom today who didn't want to know anything about the Invisalign path expander. She told me, just do something fixed. I don't want
Deal
her
with
to
it.
take anything out or putting anything in. I just want her to something fixed because I know she will lose it. So
Mhm.
that's why I feel it's important to follow the guts of the mom. You
Yeah,
know, if something doesn't sit well in your guts, just, you don't have to do it. There's like option 2, there's option 3.
I love that.
Yeah.
Um, Last question. Do you see a pattern on the occlusion for these patients who have scoliosis?
Yes.
What do you see?
Yes. I mean, this is something that I studied when I was so young, and then I realized later in practice that I see it. So basically, what we see, especially in girls who have idiopathic scoliosis, and usually they are detected, between 9 and 12 years of age. When you look at their mouth, you can see that from one side they are class 2 and from one side they're class 1.
Mm-hmm.
And you can see a bit of asymmetry. And sometimes I learned, through the years that when I see those type of bites, that I just ask randomly the mom, like, what's going on? And then I get those answers back, like, she's skipping PE, or she's we've been having those problems with her back or spines. She fell in gymnastics. They have balance issues, they have posture issues. you know and it's just it's just fascinating to me how from just looking at a bite you can literally discover a spine issue. Can you
Isn't
imagine?
that crazy that
So
it's
it
all
it hap it
connected?
ha I know it happened a few times, but even for you, right? Like, us dentists, I go to my chiro once a month,
Mm-hmm.
because if I, the stress, our body is such a stressful job. Pediatric dentistry is, when you go through so much stress, I feel like your body absorbs it. And
Yes.
just the fact, and because we do a lot of acrobatic movements on that chair, right? Trying to reach the children, and sometimes you compromise a lot of your, good posture and good ergonomics to just serve that child. And I
Yes.
feel that one time per month where I go to my chiro and then he rebalances like all my
Mm-hmm.
joints and spines, does me, does so much, blessings in my body. So it's all connected, the neck. And I also, for example, I see it in children. I have a lot of 7 or 8-year-old who have very deep bites, right? Super deep bites where the lower incisors, they almost touch the palate.
Yes.
And those are typically the boys who complain of headaches, right?
Really?
Yes, or neck pains. The mom comes and tell me, and as soon as we release the bite, we open the deep bite and we put him on clear aligners, or as soon as I treat the overjet or the deep bite, we advance a little bit the mandible, and then we put him on a more healthier side. Headaches, zero. They disappear,
Wow.
you know and it's and sometimes before they get to me, they go to pediatricians, and sometimes they're
Mm-hmm.
medicated, right? Sometimes they go, and sometimes they go to other solutions, but it's so simple. Sometimes just by checking the bite, treating the bite, those symptoms completely disappear.
So what are some options for a deep bite on a child? What are some things you
um
can
we open the bite, and usually we do it with clear aligners.
do? Okay.
And if the deep bite, in a lot of cases, the deep bite is combined with an excess of an overjet, so you
Mm-hmm.
see a retruded mandible, and that in that case, we do the mandible advancement. So it's a combination of mandible advancement
Mm-hmm.
and then reducing that deep bite, and then putting and giving him that functional bite. And even though he's on a mixed dentition, we can leave him on retainers at night towards
Mm-hmm.
him completing his full dentition. And then we go to a phase 2. And sometimes, in most cases, we don't really need a phase 2, because the job
Wow.
is, almost done. You stabilized it. And as you know, form follows function. If you treat the underlying cause, if everything, goes back in order, it's, just putting him on a good function is already a natural retainer for him.
And to bring the lower jaw forward, do you do that with Invisalign? I know that they have some bumps now on the appliances you can do. Do you do herb
Yeah,
Herbstigans?
you can do a lot of stuff. So twin block, which was the traditional way that we learned
Okay.
like 20 years ago, but now we have the the innovation or the tech gadgets that we have with, for example, Invisalign has those wings,
Mm-hmm.
that teaches the child how to, it's like a bit of a twin block associated with the clear
Okay.
aligners. There's another company called Angel that I also use, where they have the occlusal stops instead of the wings.
Okay.
That also works very well. But those are the two, companies of aligners that I use. But they're very useful, very efficient, and then kids, they tolerate them very, very well, because we do increments. So we don't do one
Mm.
full jump. We do like incremental jumps.
I love that because I think it's one of the biggest things that I get in the practice are kids with an overbite and I don't have who to send them to. Many people around me at least don't treat it, don't do anything. And I
True.
know that if they open that vertical, the tongue will find its home. You know, there's
Totally.
going to be room up there.
Totally.
I
And
can't.
and it also opens the airway
Yes.
because when you see the set of a child with a deep bite and a retruded mandible, their airway in the back is very, very narrow. As soon as you open, as soon as you rotate the mandible, they breathe better.
Yeah. And the
So
tongue
everyone
is
everyone
able.
wins.
Yeah, the tongue
Exactly.
is able to go up and forward. That's amazing. So we have a question from
But
Diana. Can you
yeah,
start these kids on a myomunch or similar if they cannot get expansion?
yeah. I have a child who was 2, and then I couldn't do anything, and I put him on a myo brace. I think it was a K0, and then boom, he was like, I was lucky because he was like the most serious 2-year-old boy I've ever seen. But sometimes you get lucky, of course. And sometimes I use a lot of myo brace as a maintenance. So
Uh-huh.
sometimes when I'm done with the treatment, I usually send them videos of like, myo just as a treatment if they're done with their sessions with the myo, like those myo brace tongue exercises,
Yes.
as like homeworks at home with a myo brace at night. And then, it helps me just, giving them something to do while they're, waiting to see me, every six
Mhm.
months. So it's a great way of maintaining. But of course, it doesn't fix everything.
Oh my goodness,
Yeah.
Dr. Payada, thank you so, so, so much for sharing so much with us. Do you mind telling everybody how to find you, share your Instagram, and let's talk about your book?
Oh, yes, my book. So do you have it?
I do.
Oh my God. Yes, yes. So this is my book, Danny and Sarah Go to Dr. Smile. Unfortunately, is not distributed in on Amazon US, but it is on Amazon Europe and Amazon GCC and Middle East. Thank you so much. I I wrote this book thinking about my patients. A lot of those little kids have the anxiety, the dental phobia transferred from their parents. So I thought giving them a story, that prepares them to the dental trip is a great way to make them feel better and to make that visit more smooth. So yeah, I mean, I wanna, if you have a distributor for North America, let me know.
All right, Area Circle, we need
Yeah,
to
that would
become a
be great.
distributor for
Yes, why
our
not?
books. Oh my goodness, it is a wonderful book. Thank you so much for writing and for sharing it with us. Guys,
Thank
have
you for
a
having me.
wonderful weekend. Thank you so much. And again, really quickly, if you want to do an advanced myofunctional therapy course, if you trying to figure out what is the why behind the exercises that you're prescribing to these patients, join us, MyoCircle. It's 8 to 9 weeks course, starts January 1st, and we have huge bonuses going out right now. You get Intro to Airway, which is a course that we recorded last year. We never sold the course, but there's 14 speakers and it's everything to introduce you to Airway. We talk about breastfeeding. We talk about muscle function. We have some huge names there. We talk about sleep. So much, but you get that one for free. It's a $1,200 course. You get it for free whenever you join Myo Circle. You get a whole free year of the Airway Circle membership and Myo Meets. The Airway Circle membership is $450. The Myo Meets is $699. You get all of that for free, and you get 100 brochures from Airway Circle, so you can keep promoting your business. Myo Meets is an online study club for myofunctional therapy. We meet once a month to go over cases, and only if you have taken Myo Circle, you are allowed to go into Myo Meets and join us. So don't wait. Myo Circle, we have 6 spots left, starts January 1st. And then the retreat. We've been talking for years about having a retreat. It's finally here, April 10th, 11th, and 12th. It's going to be in Hilton Head, South Carolina, where I live, Hilton Head Island. The house is 10 minutes from the beach, beautiful home with a pool, heated pool. We are going to have so much fun, so many fireside chats, and I cannot wait to share with you guys the topic of the retreat and who the speakers are going to be. These are huge people in the field. I know you're going to want to be there with us. You're going to have to apply. We're going to pick the attendees. So go over to the Facebook group, Area Circle Professionals, so you can get the links for all of this. Thank you so much for hanging out with us today. Have a wonderful weekend. Thank you so much, Dr. Tayara. We love you, and I can't wait to see you in Dubai soon.
Yes. Thank you so much for having me.
Thank you. Thank you. See you
Yeah.
next time. Bye.